Good evening. Welcome to the MyCP webinar for March 19th. Thank you for joining us here. My name is Paul Gross. I'm President and CEO and co-founder of the CP Research Network, and I'll be your host. And I'm really excited to have Dr. Brandon Rocque present on rhizotomy in cerebral palsy. So let me just tell you the way we do this is I'm going to give a short introduction to the CP Research Network and then turn the microphone and slides over to Dr. Rocque, and then we will open the floor for questions and answers. So I'd like to talk a bit about why CPRN, or the CP Research Network, exists. We were founded out of a very meaningful NIH meeting that happened in late 2014 about the state of the science and treatment in CP. At the end of that meeting, the organizers stood up and talked about the key things that they heard that needed to happen, and they actually had us form task forces and report back to them. And one of the task forces was to create a national registry, and I was on that task force with Dr. Deborah Gabler, to do more comparative effectiveness research, to compare interventions. This is a page from Dr. Iona Novak's traffic lights paper, which is free and available on the web, and it talks about the level of evidence for all the different interventions. And you can see there are a ton of interventions for kind of the same types of outcomes, and therefore comparing them and figuring out what's most effective is very important. We did a little bit of a review of the landscape, and the study of adults was paltry, if at all existent, at that time. And there are probably 4 times as many adults in the United States with CP as there are children. And there was a real need to develop a basic and translational research agenda for CP, a need to bring young investigators into the field, and to create much closer connections between patients and families and investigators. So the CP Research Network was founded out of combining all of those task forces together with an objective of optimizing the lifelong health and wellness of people with CP and their families through high quality research, education, and community programs. One of the first things we did was we came together in 2017 and did a patient-centered research agenda, which was published in 2018. And that's really guided a lot of our work so that we stay focused on the needs, wants, and priorities of the community. So I'm going to take a moment to read our vision. I think we're doing a good job accomplishing this vision, which is by engaging the community and a very large number of health systems, 35 at this stage, in a learning health network for cerebral palsy, i.e. something that uses the data from the treatment of people with CP to improve CP. We'll collectively focus the research and care of people with CP on health issues that are pressing and important to them. And we will gather and share lived experiences from the community member and measure the aspects of the healthcare process so that we can continuously improve their health and well-being in ways that matter to them. So some key milestones since we launched the network. Our education pillar has done a number of things. We've released several toolkits. Most recently, I shouldn't say this month, I got to update that, but we released the Dystonia CP toolkit back in November. But a number of toolkits. The leading one is the CP toolkit, and that's served thousands of people that get a diagnosis of CP. And then in 2020, we launched MyCP, which does personalized information about CP and what's important to read and learn and know. And then we do monthly webinars like this webinar to engage the community in our work. From a research and quality improvement perspective, we were founded around that concept of creating a registry or a database of people with CP. We're up to 17,000 patients in that registry. And then we have a community registry, which is intended to gather information for people that are not in the hospital. And that's got about 3,000 people in it. I talked about our patient-centered research agenda. We've gone on to get public funding from NIH and then a partnership with the largest private funder of CP research. We run quality improvement initiatives within the network, which is how do you do a systems improvement to improve an outcome, like having less invasive hip surgeries or fewer infections from placement of a pump are examples. We are very academically focused. Oh, I see another data point I needed. We just actually got 2 more publications in the last month, and so we're up to 18 publications, lots of academic presentations, and lots of manuscripts under still being written. And we're now starting to do a lot of a secondary analysis of the data that is in this registry, meaning, so we collect this data in the registry, what can we learn from it to generate new knowledge? And that's a lot of what tonight's presentation is about by Dr. Rocque. And then on with the wellness front, we've partnered with the National Center for Health, Physical Activity, and Disability to offer a wellness program to adults, and we're now working with them to develop a pediatric program, in addition to rolling out some programs in the DC metro area. So I said a registry is a database. Here's just some data points from that. So gross motor function classification system is it's like a vital sign in CP. It's about how people move around through the community. And you can see the distribution, the very large numbers of people we have at each level there. And then you can see the age distribution on the right, where you can see that I don't have the percentages on this slide, but roughly 26% of the people in the registry are actually adults. So that's another important aspect of our study. The community registry, on the other hand, gathers data from people on the internet, not people coming into a clinic. And you see a very different distribution of GMFCS. And then from an age perspective, you see that it leans way more towards people that are adults. And that's because this is reflective of the internet bias of who is out there advocating for themselves, contributing their data to research to improve outcomes. So the network is 35 centers, as I mentioned, spread across the United States. The green circles are around sites that are doing lifespan data collection. The green pins are all collecting data and putting it into the registry. The yellow pins are working on the technology, and the blue pins are sites that have raised their hand and said they want to join the network but haven't gotten through the agreement and data sharing use agreement as of yet. So our strategy on research is to stimulate the research ecosystem such that we can let 1,000 flowers bloom. So we've done that by setting a patient-centered research agenda, as opposed to just what do the investigators want to investigate? How can we connect them with the community so that the research will be most meaningful? We build infrastructure, so registries, our network, our data center, to make it so that investigators have an advantage when applying for funds. And we try to balance between generating new learning or new evidence and just improving care, and that's that quality improvement concept. And then we can use our registry to monitor the implementation of different quality initiatives and what are the outcomes that people are experiencing. So I want to quickly give people a view of what this infrastructure has done in terms of letting 1,000 flowers bloom. We're not quite up to 1,000 flowers yet, but we have a standard operating procedure by which anybody can propose a concept. It goes through a couple cycles of review, and then it either gets funded internally or it goes for external funding. If it's funded, it gets implemented, it collects data, it analyzes it, and then it publishes it. So I'm going to run an animation here since our founding in 2015 through 2024. And you'll see these sort of off-white circles are childhood-focused studies. The hot pink is adults, and the gray are lifespan studies. So I have no idea how well that works over Zoom, but that is the animation it gives you an idea. The green circles are efforts that we have in the quality improvement area. I didn't document that on the legend. Okay, so the whole idea of the CP Research Network, what its unique value is that connection between the electronic medical record when people are treated to get data into the registry, as opposed to other processes that tend to be involve duplicate data entry. Our ability to link the patient-reported outcomes to the clinically validated data that's entered by physicians. And this data can then be used for generating ideas for studies, looking at practice variation. You're going to see both of these things in today's presentation. And it provides a platform for doing continuously doing research and just continuously improving outcomes. And in particular, we can study long-term outcomes, which is really important. And so this is the way we implement a learning health network. So with that, I am really excited to introduce Dr. Brandon Rocque, who is a professor of neurosurgery at the University of Alabama, Birmingham. He's a pediatric neurosurgeon at Children's Alabama. He kindly dedicates his time to chair our manuscript review committee for those 18 publications that we've had. He reviews them as they come up now. He's stepped into that role. And he's an associate PI in the network overall, and he was part of the original team that defined the registry for neurosurgery. So with that, I turn it over to you, Dr. Rocque.
All right. Thanks, Paul, for that introduction and for the opportunity to speak to this audience. I'm excited to be here tonight. I'm going to show some slides. Can you guys see those okay?
We can.
Excellent. All right, so the topic tonight is about selective dorsal rhizotomy or dorsal rhizotomy as a treatment for spasticity in cerebral palsy. Now, in an ideal world, I would be able to tell you what works. How do we make people better with rhizotomy? But I'm not going to tell you that tonight because, unfortunately, we're not quite to the point that CPRN has the potential to get to. And that's because, as Paul described, the goal is to pull a tremendous amount of data directly out of electronic medical records. So you don't have the trouble of a researcher walking their way through the record and pulling out data to try to do a research project. It just comes automatically into a database, and then we, the researchers, can find the answers. Unfortunately, we're not quite there yet. So what we do have, however, is a lot of centers contributing a fair amount of data on their surgical patients. So as Paul said, I was one of the original, one of the neurosurgery group that defined the neurosurgical terms and variables that we were going to use in the registry. And since its inception, we've been contributing patients and information to the registry at our center, but we don't have the ability to download anything from the electronic medical record yet. It's still my team manually plugging data in. And that's unfortunately the case for a lot of the other sites that are still working up to that ideal state that Paul described. So what we have, and I'll show you tonight, is information about how surgeons do rhizotomy. And so I'm going to present that in some detail. I'm not going to be able to tell you how this impacts the outcomes or how patients do after these things. I'm just going to be able to tell you how differently people do this. So hopefully that's still interesting. We'll get into it. So what is SDR, selective dorsal rhizotomy? So this is an operation that we do on the nerves as they're coming off of the spinal cord. So there really are two types of nerves. Your spinal cord, as you know, it's the connection between the brain and the rest of your body. The nerves that come off the front side or ventral side of the spinal cord are the motor nerves. Those are the ones carrying the signal from the brain to the rest of the body, telling your legs to move, etc. Then there's the dorsal nerves, the nerves that come off the back side of the spinal cord. Those are carrying the sensory signal from the periphery, from the body, back to the brain. And in rhizotomy, those are the nerves that we're working on. Now, we do this because of some ancient history. So in the late 1800s, these papers that I'm showing now, they showed that in an animal model, if you cut those sensory nerves in, for example, a cat that has a brain injury, you can actually decrease the spasticity in the animal's legs by cutting the sensory nerves. And what that led to is these studies in humans that showed that, yes, we can do that in humans as well. And it was first done in the early part of the 1900s, kind of fell out of favor for a while, and then was brought back in about the 1960s, 1970s as a treatment for individuals with cerebral palsy. And we know it works, right? We know it works because there have been multiple randomized control trials comparing this operation, selective dorsal rhizotomy, to other treatments for spasticity, specifically for intensive physical therapy. And in all of these studies, the reduction in spasticity and the improvement in function that you get from rhizotomy has been superior to the other treatments. So we know this is a good operation. We know it works. We know it helps. But there's a lot of different ways to do it. So first, the first thing I want to delve into is just how do we get to the nerves that we're gonna operate on here. So the original description is depicted in this figure here. So we actually make an incision in the back, we expose the bones of the spine, and we take off 4 or 5 of the lamina, right? So these are the bones you can feel. If you feel your lower back, you feel that bone, that pointy bone in the midline. That's the spinous process, the lamina. We got to get that out of the way to get to your nerves. All right. So the original description is this 5-level laminectomy, and then we select nerves at each individual level and try to figure out which ones we should cut. Well, in the mid-2000s, Dr. Park in St. Louis published this new technique where we only take off 1 or maybe 2 levels of bone, and we can do all the work from a much smaller incision. So this became a very popular way to do the operation. We do not really know if it's better to do the larger, more bone removal or the smaller operation. And I'll tell you a little bit later why we think one might be better than the other, but we honestly just don't know. And then there's a couple of other, techniques that are much less commonly used, like this one here, where you just take off a little bit of bone and sneak your way in. That's not very, very popular. So again, what we're trying to do is effectively we're just cutting nerves. So we've got to get to the nerves and select which ones we're going to cut, and then cut nerves. So again, this is an MRI scan. This is showing essentially a cut right down the center of the body, and you're looking at it from the side. So these are the bones of the spinal column, the vertebra. Everything white here is fluid. So this is the spinal fluid surrounding the spinal cord. The gray stripe here is the spinal cord, and you can't really see them in this picture, but there's a whole bunch of nerves that come off the bottom of the spinal cord. Those are the nerves going to your legs. Here's a schematic of what this looks like if you look kind of straight at it, right? Bottom of the spinal cord here, and a whole lot of nerves coming off. Now, we can determine, again, remember I said that we're doing a dorsal rhizotomy. So we want to work on the dorsal nerves, not the ventral nerves. Basically, we want to protect those motor nerves traditionally, and we only want to work on the dorsal nerves. And we can determine by looking at the nerves which one's dorsal and which one's ventral. But we can only do that in a couple of places. So we can do it looking at the bottom end of the spinal cord right here. And I'll show you some pictures and videos of what this looks like. And we can also tell dorsal from ventral if we look right where the nerve exits the spinal canal. Right, so 2 different ways we can do the operation. One, focusing all of our attention here, and the other by looking at every single one of these levels. All right, selective dorsal rhizotomy. I've told you what the dorsal part means, but what about selective? What does selective mean? Well, the principle here is that we're using electrical stimulation to determine which nerves we're going to cut and which nerves we're going to leave alone. So when this was originally described in the 1970s, the idea is that you're going to stimulate each nerve, and the ones that make the legs move the most, the ones that have the biggest response, those are supposed to be the most pathologic nerves, the ones that are causing the problem. So we cut those nerves and we leave alone the ones that are less active. But it turns out that there's all kinds of things that affect the response that a nerve gives you if you stimulate it. If the nerve is wet from spinal fluid, how much tension you put on the nerve. Have you stimulated that nerve before? Every little thing affects how the nerve responds. So it's very difficult to reproduce a study that says stimulation is important, right? So there's a lot of variation in how this stimulation is performed. Now, I'm going to show you this video here. So I apologize if anybody's squeamish. This is a surgical video that shows you what we're doing. Right, so this is the spinal cord in the middle here. You can see it looks different. And these are the nerves as they come off of the spinal cord. And this is not my video. I've stolen this from somebody, and unfortunately, I can't remember who I stole it from. So I can't even give proper credit for whose video this is. Now, some surgeon might watch this recording one day and say, hey, that's my patient. But so you can see what we're doing here is we're moving the nerves so that you can see right there, right? There's the side of the spinal cord. So all these nerves are the ones that are coming off the backside. Those are the dorsal nerves. And all these nerves down here, those are the ventral nerves, the motor nerves. We're going to leave those alone. So we're going to separate the dorsal from the ventral and only work on the dorsal nerves. I'm going to skip ahead here a little bit because eventually what we're going to do Oh my goodness, sorry about that. I want to go to about here. Right, eventually we're going to stimulate. See, now I've got two hooks, and those hooks are providing an electrical stimulus across that nerve. And using that stimulus, the surgeon's going to decide whether or not to cut that nerve. But here's another important point, right? You can see there's a bunch of nerves in there, and they're different sizes. And one nerve may not be exactly the same size as another. But the other thing is that we can actually divide the nerves. Oh man, I'm sorry. My PowerPoint skills are failing here. Sorry, guys. Right, there we go, right there. Do you see that move right there? Right, so the surgeon's going to actually take this hook and going to divide this nerve into smaller bundles. So it turns out you can take each of these nerves and you can divide them into smaller and smaller bundles, and you can make smaller and smaller distinctions between which nerves you want to cut and which nerves you want to save. So some surgeons do this operation. They may only test we're all testing a bunch of nerves, but some people may test 10, and some people may say, well, I tested 100. Well, there's the same number of nerves in there for every patient. It's just how much you divide it up that makes a difference, right? And we don't know which one of those we don't know if that affects outcome. We don't know which way is better. Right, so what did we do in this study, right? We've used the CP Research Network, the CPRN registry, to collect a whole bunch of information about how people do rhizotomy. These data are collected in a prospective fashion, so they're entered. We don't have to look back into the medical record to figure this stuff out. This is stuff that's put in as we go. And basically what I'm going to do is give you just some summary statistics of how many of these surgeries we do and how people do it different. So here's the meat of the talk, and this may not take all that long, so bear with me, and there'll be plenty of time for questions at the end here. We've got a total of 567 surgeries that have been entered in the registry. The average age is about 7 to 8 years old. That's about what we would expect. Traditionally, we do this operation in kids that are in the maybe 3 at the young end to maybe 10 at the older end. But you can see here, this is really interesting. We actually have patients entered in the registry that are as young as less than 1, which was surprising to me, and as old as 33. I've definitely heard of adults having this operation, but it's really not very common. In my own practice, the oldest patient I've done this operation on is 16. And that patient did very well. So there's no reason we can't do this potentially on adults or teenagers, but just traditionally it's done in that younger age range. There are more male than female patients, and that kind of mirrors the distribution of CP. We know that. Race, pretty similar to what we see across the United States. This is a national sample, so we would expect the racial distribution in the sample to be about what we see nationally, and that's pretty close. Now, here's the interesting thing, GMFCS, right? This does not look like the graph that Paul showed earlier. We see the majority of our patients are in the GMFCS 2 and 3 range. Now, remember what this means. So if you're GMFCS 1, you can walk independently, you can, good enough motor function that you can climb a flight of stairs while carrying an object. GMFCS 2, much more tentative with getting around on uneven ground, independent on even ground. GMFCS 3 means you require some assistive devices. GMFCS 4, you're really not able to propel yourself independently without a lot of support. And GMFCS 5 is essentially dependent on others completely for mobility. So if we look at this, what the traditional rhizotomy patient that all the textbooks will talk about and the papers are written about, those are GMFCS 2 and maybe 3 patients. Definitely some 1s as well, because the goal of rhizotomy is traditionally to help people walk better, improve their gait pattern. But you can see that across the network, we've got 35% who are GMFCS 4 and 5. So these would be classically not considered a candidate for rhizotomy. But so obviously we're doing this operation maybe for different reasons. It's not just to help people with their ambulation. Maybe we're doing the operation also to help with the pain of spasticity or to ease care and cleaning, changing, bathing, things like that. I will say that in my own practice, I do quite a number of rhizotomies on children who have GMFCS 4 and 5, and it's been quite satisfying. Parents are generally pretty happy with the results of this surgery. And you can see that I'm not the only one doing that. It's happening across the network too. Now, to start to talk about the variations that I went over before, right? We talked about doing this operation through a single level, are doing it through multiple laminectomies. We take off multiple levels. And you can see that it's almost exactly 50-50. Some surgeons are doing this operation through the small approach, some through the larger approach. But importantly here, out of those 500 patients, we're missing almost 200 of them. So we have to be very careful with how we interpret data when there's that much missing. For what we have, it's about 50-50. In many cases, traditionally, their physical therapists are involved in the operation as we're working. So not only are we monitoring the electrical response when we stimulate a nerve, but we've got a therapist or a rehab physician whose hands are on the patient during the surgery. They're feeling the legs. When we give that stimulation to the nerve, they say, okay, these are the muscles that I felt move. That's how the operation is traditionally described. And you can see that about 300 patients, so about 60%, still use that technique, but plenty, more than 40%, are not using any kind of intraoperative manual muscle testing or manual testing at all. There is a technique where at the end of the operation, you can put the bone back on. The bone that you've removed to access the nerves, you can actually replace it. That's called a laminoplasty. And that's been being done about 1/3 of patients. Traditionally, we don't put the bone back on at all. We leave it off. That's being done about 2/3 of patients. So why should this matter? Well, remember, here's the multiple level laminectomy, and here's the single level laminectomy. Well, what might happen if you were to leave a lot of bones off? You might get this exaggerated lordosis, right? That's called that's a hyperlordotic lumbar spine. Right, because those bones are missing, you may end up with this kind of sway back. Note, Paul, that I stole this from the internet too, from somebody called Clarendon Chiropractic. So if you're putting this online, you got copyright problems. Or you might have the opposite problem, right? Where we've got something called kyphosis, where the spine bends forward. Right here, you can see this is there's a curve here where the spine is bending forward. That's not supposed to happen either. Now, theoretically, if we put the bone back on, we might reduce the risk of those spinal deformities developing in the long term. We actually really don't know if putting the bone back on actually does reduce the risk. It's just a theory. But as you can see, most people leave it off, about 1/3 put it back on. What do we do about pain control after the operation? Well, it turns out this is a very uncomfortable surgery. Nerve injuries actually hurt. So we're going in and cutting a proportion of the nerves that are going to the legs, and that's quite uncomfortable. So how are patients' pain managed after the surgery? A lot of times in the past, people have advocated for something called patient-controlled anesthetic. So a PCA is the pain button, right? When you're hurting, you can press the button, you get a dose of pain medication. That used to be much more common, I think, but as you can see, it's very rarely used in our modern rhizotomy practice. The other thing that people have done in the past, and there's quite a number of papers about, is something called epidural anesthesia. So you put a catheter into the space outside of the dura and deliver a slow, continuous infusion of anesthetic medication into that space. This is what's used for pregnancy. You've heard of epidural anesthetic for delivering babies. This also used to be very, very common, but now you can see it's only being used in about 30% of patients in the registry. On the other hand, IV pain medications, so post-surgery, people get IV morphine, Dilaudid, things like that. That's very common. Obviously, we're still using that. And you can see a little bit over half are getting gabapentin, which is a medicine that started as a seizure medication, but now is used almost exclusively for nerve pain. I started using gabapentin in my practice as a scheduled medication after rhizotomy for a good 6 months after the surgery. I started this 5-6 years ago, and I've been extremely pleased with how that seems to help people manage the pain of rhizotomy. So looks like I'm not the only one doing that. It's about half the patients in the network. And then finally, scheduled doses of minor analgesics, Tylenol and ibuprofen. There was a paper published by my mentor on that method several years ago, and that looks like it's been taken up by a lot of folks as well. So 2/3 of people are using that regimen. Now, here's the really interesting part, at least in my opinion. So how many nerves do we test when we do a rhizotomy? You saw that video earlier, right? On each side, there's a bunch of nerves, and we're going to test nerves and then decide how many we cut. Well, these are the averages across the entire network. And you can see on average, we test about 30 nerves on each side. and we cut a little less than 20. So that's exactly what I would have expected to see. About 2/3 of the nerves on each side are going to get cut. That's pretty standard, what I would have thought. But the range here is remarkable. Some people are testing as few as 5 nerves and others as many as 140. Now, as you saw in that video, there's the same number of nerves in there. It's just how much work you do to separate them out into tinier and tinier little bundles when you do your testing and your cutting. And then finally, what proportion of the nerves do we cut? As I said before, right, it's about 60%. So here we have exactly that, about 60% of the nerves are cut. But you can also see that sometimes folks are only cutting 20%, and sometimes folks are cutting 100%. Now, 100% doesn't make any sense to me because there's no way we would cut every nerve going to your legs. You'd have totally numb legs after that. So that makes me worry that what we're actually seeing here is some incorrectly entered data. Right? People are putting in things that are not exactly describing what they're doing. Right? That makes me think there's a problem with the data collection. All right. Now, the really interesting part, I'm going to go through all those variables again, and Paul's going to love this because this is broken down by each center, each hospital that's contributed data. So these are the CPRN codes. They're supposed to be meaningless. I know which one is me, but I don't know which one is any other site. And you can see, right, distribution of male, female is about the same, nothing exciting there. Now the age, now things get a little more interesting because if we look at the age, we've got some centers that are treated that their average age is as low as 5 years old. And some centers, their average age is as high as 9 years old. So there's definitely some variation in who's going for surgery. Here are those folks that have treated infants. It looks like it's happened maybe at 2 sites, and even a couple of sites that are treating people up into their 20s and 30s. Race, also not a big surprise. If you know where these sites are, and again, you're intended to not know where these sites are, you can say, okay, some of these places have a higher or lower population of Black, Asian, other races, and that is pretty well mirrored in these data. So this is not a big surprise. But GMFCS is interesting because you can see that some places are doing a lot more of those GMFCS 4 and 5. Some place like this site here is doing more of GMFCS 5 than anybody else, than any other category. Now that's a bit shocking to me that most of their rhizotomies are actually these GMFCS 5. And other places are a little bit more traditional, where the most of their cases are in that 3 and 4 range. And so there's definitely variation on who's being selected for surgery across these sites. Who does the single level versus the multi-level technique, right? Some sites do mostly one or mostly the other, but there's a couple that are doing both. How do these surgeons decide which of these techniques they're going to use? Right? We don't know the answer to that, not from these data, but there's definitely quite a bit of variation. Did we put the bone back on or not? Well, it turns out most of the cases where the bone got put back on is at 1 center. Oh no, 2 centers. Excuse me. So 2 places that are doing that. What pain medications there are people using? Different across the board. And then what I find to be the most interesting of these data is how many nerves are we testing? Right? So you can see that we go from 5 as an average to 20 as an average to as high as 70 as an average number of nerves being cut. Now that's a huge amount of variation. Now this site only entered 4 rhizotomy patients into the registry, but they are taking those nerves apart into smaller and smaller bundles as they do the testing. Right, a minimum of 47 nerves are tested. Each of these 4 patients, 47 is the lowest number of nerves that this site tested. That's a lot of nerves. I don't think I've ever tested 47 nerves. So they're working a lot harder at deciding which nerve to cut. And then the last bit of difference is that percentage of nerves cut. Traditionally, we think we're going to cut about 2/3. You can see here that the lowest number of nerves is just under half. And then the highest number, if we don't count this, which I think has got to be an error as we discussed, is pretty close to 2/3. So 0.65, a little less than 0.66. So that, again, a lot of variation in how many nerves people are cutting. So in the end, what I've just shown you is that we've captured a tremendous amount of variation in how rhizotomy is performed. What are we missing? Well, we're missing kind of a lot still. Every one of these surgeons, we presume, is doing some type of electrical stimulation of each nerve to figure out which nerve to cut. What we don't know, what we don't have a way to collect yet, is what are the exact settings on their stimulator that they're using. How are they using that electrical stimulation response to make their decision? Are the stimulation parameters the same? How do they use the info? If I see one response, I might decide to cut. Somebody else might see the same response and decide that nerve needs to be saved, right? We don't have a way to quantify that or study that yet. You can see that there's a lot of variation on the number of routes tested, how many routes are cut. And then, of course, the most important question, we've got all this variation, and what we don't know is how does it affect outcome? What we really want to know is, do patients do better with one of these techniques versus another? And we don't have a way to study that yet. Now, I'll put in a plug for CPRN, because if anybody's going to study this, it's going to be this organization. Because once we achieve Paul's vision, where we're actually pulling data from the EMR, and we're able to have surveys and follow-up data reported directly from patients and from families about how successful they feel the operation was, objective measures about how their gait has changed or how their spasticity has changed. Once that is also included in the registry, this is going to be incredibly powerful, because we'll be able to tell which of these techniques is the right technique for this operation. In order to study a surgery, you have to have multiple different ways that it's done and test which one of those ways is better on the outcomes. If we had no variation, we wouldn't be able to test which one's better in the final outcome. But at least now we know we have the variation. So in the future, we can do the study on outcomes, and that will be great, but we're not quite there yet. So with that, I'm going to stop talking and leave you guys with at least 15 minutes to grill me on this presentation.
Well, that was great, Dr. Rocque. Thank you so much. A lot of detail there. I think you did a great job in general explaining lots of technical terms too. I wasn't sure if I know what the words mean, but I'm going to tee it up. I wasn't sure if in saying dorsal and ventral, if you made a reference to motor, but is there anything else to say about dorsal versus ventral?
Absolutely. Thanks for that. So here's our spinal cord. And again, we're looking, this is a slice MRI right down the middle, as if you're looking at the person from the side. So this is the front, this is the back. The ventral nerves are the nerves that come off the front side of the spinal cord. So they come this direction, right? And they then run down in the canal and exit at each spinal level. Right? So the ventral nerves are the ones that send the signal from your brain to the muscles. They make your legs move, right? The dorsal nerves come off the backside of the spinal cord, also run down this canal, exit the same way that the ventral ones do. But those nerves are the sensory nerves. They're carrying the signal from the legs back to the spinal cord, back up to the brain. They are the sensory nerves. Does that help?
That helps. I have other questions that I would serve up to you for everyone, but I want to turn it over to we've got a pretty big audience here. So you can either raise your hand and get called on, or you can put a question in the chat. It doesn't look like we have any there yet. And so I'll let Paul Staunch's question stand first. So I don't know if you can see it there, Dr. Rocque. Read it
Yeah. So has there been any investigation into nerve selection made by another method? So not stimulation and physical observations. I don't think so. And I'm having trouble thinking of what another method would be. So the way we do this, and right, so we're gonna use these little electrical probes, right? So these hooks are the thing that carry the electricity. So once we get a nerve selected here, we're going to run a current that goes from one hook to the other. So that allows that stimulates the nerve, and it causes the nerve to send a signal wherever it's going to send a signal, right? And then based on the response to that electrical stimulation, we're deciding which nerve to cut. So these hooks are there we go. These are the things that we're using to stimulate. You can look at the electrical response by placing needles into the muscles in the legs. That's one way to do it. And you can look at how the leg physically responds by feeling the muscles and watching them contract. So I am not aware of any other way to grade that response. No.
Okay, there was a hand raised, but it went down, so I'm going to assume that's question's no longer standing. Amy Wolf asks, is the recovery time in patients who have multi-level laminectomy versus, is it greater in patients that have multi-level versus single level?
Well, so the incision for a multi-level is definitely longer. So if I'm going to do an operation where I take off 5 levels of bone, I've got to make a really long incision in your back. If I'm going to do an operation where I take off 1 level of bone, I can do that through an incision that's about 2.5 centimeters long. The pain of surgery, often, with rhizotomy, it's a little bit different because we're cutting nerves and that causes some pain. But most of the pain that people get with surgery is actually from moving muscles. And there's big muscles on either side of the bones of the spine. We got to move out of the way. So yes, the larger incision, the longer incision is going to be more painful than the smaller incision in general. And you're probably going to have a longer recovery period. I don't have studies that prove that, but yes, that's what I would expect.
Okay, great. So Sherry Bartel's question is next up. Very informative. We work in the adult population, GMFCS5. What negative outcomes should be considered for cutting more nerves in a non-ambulatory adult who requires 24-hour care support? Our individuals have severe spasticity.
So theoretically, if I were to do an operation and cut every one of the dorsal nerves, all of the sensory nerves, then what would happen is you'd have completely numb legs, no sensation in the legs at all. That's presumably a bad idea, right? We don't want to do that. In the traditional operation, we cut about 2/3 of the nerves. And what happens then, for a short time, patients will have a little bit of patchy sensory loss. They'll say, it feels a little weird here, feels normal over here. And it's kind of here and there on the legs. But over time, the nerves that are left, they kind of expand with the territory that they cover. So in the long term, it doesn't seem that people really have that much loss of sensation. Now, when I am treating a child, I'm a pediatric neurosurgeon, so I'm only treating children. So when I'm treating a child with GMFCS5 who's incredibly tight, lots of spasticity, very impaired by the spasticity, I will tend to be a little more aggressive. I cut closer to 3/4, 75% of the nerves rather than 2/3. My goal is to make sure that I've addressed the spasticity because I'm not that worried about leaving a little bit worse numbness in the legs. I don't think that the patient, the caregiver, is going to notice or be concerned much by some numbness in the legs. You have to be a little careful with that in people who are walking because they need to have that sensation of where their feet are. But in the GMFCS5 population, it's much less of a concern. So my answer to your question would be, I don't think there's a lot of negative outcomes that is associated with cutting more nerves until you get to a point where you've cut too many nerves. And I don't actually know where that point is.
Great, thank you. John Borland asks, is the low number of adults receiving SDR because adults with CP are not being tracked to recognize the need?
I don't know the answer to that. This operation has always been done on children primarily, and I don't see a good reason why we don't do it on adults. Now, part one, so let me back up a little bit. When I have not talked at all about physical therapy today. And in general, we think physical therapy is a crucial part of getting results from rhizotomy. Surgery is just step one. The therapy is very important, and that's a couple reasons. Number one, part of the strength in the legs of these kids with spasticity is their spasticity. So as we reduce that spasticity, their legs are going to feel weaker, and they're actually going to maybe have a little bit harder time with some tasks. So what comes after rhizotomy is generally 3 weeks of very intensive inpatient physical therapy. That's both to strengthen the legs again, and they do get the strength back, but it's also to teach them how to use, we call it teach them how to use your new legs, right? The legs are going to feel different. They're going to move different. We want to teach them a more typical gait pattern, a more efficient gait pattern right away. So it's a lot of intense therapy after the rhizotomy. What we don't know about adults is how well they can respond to that therapy and get the same kind of benefits that we see in kids. In kids, it's sometimes miraculous how much better their walking is after this operation. There are some case series, like a handful of adults that have been treated and have been reported in the literature, and the results seem to be pretty good, but we just don't have nearly as much information about rhizotomy in adults.
Great, thank you. Question about what are the outcome measures that are being collected by CPRN for SDR? And then asking is GMFM gait measures, modified Ashworth.
Yeah, as far as I know, right, GMFM, Ashworth, dystonia, yes or no, quality of life measures, these are all being collected to some extent. And there's a lot of different ways to collect some of these measures. You know, the GMFM, it requires a physical therapist to go through a kind of an extensive evaluation, but CPRN has a way, if you're doing that in your clinic, to put that into the EMR and it gets immediately dumped into the registry. Quality of life is a patient-reported outcome, right? We can't have, if a physician doesn't grade your quality of life, you grade it for yourself. So CPRN does have a way to put a quality of life instrument, something that measures quality of life, into the EMR. The EMR can then push that out to the patient, right? Patient reports it, and then it gets back to the registry. Paul can tell you more, I'm sure, but there's also ways that CPRN and MyCP can directly ask you about quality of life. I can give you those quality of life surveys, and then you send them back in. So there's a number of different ways that we can do this. And to do this study well, we're probably going to need to use all of them. How do I do, Paul?
And I will just add that we are, a number of sites use the gait outcomes assessment list for the ambulatory population and the CP child for non-ambulatory population. We are in the process of gathering that data from the sites that do it. It's not automated. There are some sites that are doing it in their EMR, and it will be automated. And we actually have a small grant where we're implementing a way that it can be done electronically through CPRN as a pre and a post for surgery, and also contribute the data to the registry. So go ahead, Dr. Rocque. Looks like you wanted to had you already brought that?
I was just preparing for the next question.
Okay. I think the next question was, do you have an opinion on ventral rhizotomies as far as an outcome?
So I'm going to combine that with the question that comes after that. It says, I know there was a slide earlier about dystonic CP, and I'm wondering about the impact of dystonic movements after SDR. So again, historically, if I look back at the way this operation has been described in the past, dystonia, the presence of dystonia, is considered a contraindication to rhizotomy. So if you have a lot of dystonia, you cannot get a rhizotomy. Now, the reason for that is that you do the rhizotomy, it reduces the tone, the stiffness, the rigidity that comes from the spasticity, but it does not affect the dystonia. So now you've got somebody, if you had dystonic legs before, now they are able to move better and still dystonic. So you can actually see a worsening of the dystonia if you do rhizotomy in somebody that's got severe dystonia. So in my early practice and the way I was trained, the answer is if there's any dystonia, no rhizotomy. I think we are evolving in the way we think about this. Now, if I see a patient whose problem is primarily spasticity, and they've got a little bit of dystonia too, I'm perfectly comfortable doing a rhizotomy on that patient, and they tend to do pretty well. It's the people that have primarily dystonia as their main movement disorder that I'm not comfortable doing a dorsal rhizotomy on. Now, back to that first question about ventral rhizotomies. The ventral nerves, as you recall, those are the motor nerves. Those are the ones that make the muscles move. So if I cut ventral nerves, I'm going to just make your muscles weaker. That is a potential treatment for dystonia. We don't have that much data on ventral rhizotomy. There are definitely some folks who are doing it. And I don't think I showed data on ventral rhizotomy in this study, but there are, I think, about 18, maybe 20 patients included in the registry who have had ventral rhizotomies. So we know that some folks are doing it. We don't have great data on how well it works yet.
Great. So the next question I know there was a slide earlier, I know that was combined. In reviewing the literature, we found that, so this is the question about single level versus multi-level. And I know there has been some literature, but you mentioned that the jury is still out. Do you know anything about
Well,
that study and whether or not, why you say that the jury is still out?
so yes, the study that you're referencing is probably this one here, this Park and Johnston 2006. So this was Dr. Park's, one of his major contributions was popularizing this single level technique. And yes, it has been reported to have a lower risk of spinal instability in the long term. So you are correct that that is out there in the literature, but it's a relatively small study. And the problem here is that the spinal deformity often doesn't develop for a very long time. So in order to really know the answer to this question, we'd need to have 5 and 10-year follow-up, and those studies are very hard to do. So I will say that in my practice, I do the single or maybe 2-level laminectomy. I do believe that that's probably a better option, but if the surgeon is still doing, if your surgeon is doing a 5-level laminectomy, I'm not sure that that's a terrible idea, right? That's probably still pretty good.
Great. So will CPRN be looking at OT involvement after SDR? The use of movement with a reduced tone often makes ADLs easier and kids can be more independent. But I get the sense that not many OTs see these patients post-op.
So yes, we are looking not necessarily specifically at OT, but that's a fascinating observation. We are doing this operation on the nerves going to the legs. Do we expect to see improvement in hand function after a lumbar rhizotomy? Absolutely not. But we definitely see it sometimes. So maybe one explanation for that is you're reducing the spasticity in the legs. Kids don't have to think as much about what they're doing with their legs, right? And so now they have more, more brain power to focus on, on upper extremity movements. So that observation, that is something we are studying in CPRN. How well does rhizotomy affect upper extremity function, both spasticity and use of the hands? That's definitely something that OT is very much involved with, and they certainly should be partnering with us on that. Yeah.
And I know there's a lot of interest in the network about studying some of the things that are the unintended but positive side effects, like how will people attend in school if their legs aren't having conus or spasticity and whatnot. And so
yeah, and how strong their voice and their breath are. That's another the thing that people have observed is better after rhizotomy. Yep.
So I'm going to actually skip to the last question for the last question of the night, because I have a hard stop, unfortunately, tonight. Can you speak to how oh, it just moved. Can you speak to how you are evaluating and grading dystonia to determine how much is too much?
No, not really. I mean, this is a really tricky question because dystonia, we know it when we see it, but the methods for grading it, there's the one I'm most familiar with is the BAD score, the Barry Ashworth dystonia score, which essentially is just graded as a little, more, and a lot, right? So it's very subjective. This is also an area of active research by CPRN. There's some CPRN investigators, particularly Buma Aravamuthan, who are very interested in how we keep track of dystonia and measure it, and we need to do better at that.
Yeah, that's a great answer. Well, Dr. Rocque, I have to thank you for a great in-depth, very honest presentation about what we have, what we don't know. I am really excited to be able to get more outcome measures into place so we can do some retrospective and then prospective studies of this. There's so much more that can come from this work and so many more studies that are being spawned because of the practice variation we saw. So I want to thank you so much for your time, your patience in getting this publication done. And I really look forward to it and appreciate the time this evening. So thank you all. Thank you, Dr. Rocque.
My pleasure.
Great
Thank you.
presentation.